the years and have been part of the Deeds Commission since the beginning. So I look forward to our work this year. Look forward to working under our new chair. Thank you.
Thank you very much, Delegate Bell. And Delegate Price, if you would introduce yourself.
So I'm kind of new, got here this year, was the immediate former chair of the Behavioral Health Committee, Subcommittee, still on that subcommittee and still very interested in the progress that we can make and glad to be here. Thank you.
Thank you. And Delegate Ransom.
Thank you, Madam Chair. Delegate Ranson, I represent Caroline County, King George County, Westmoreland County, Northumberland, Richmond, and Lancaster County. So a large portion of the rural communities. I've been on the Deeds Commission since its fruition and look forward to our continued work as we are going to face many challenges, especially during COVID. And my concern has always been for our children. And that's an area that's been of great interest to me. So looking forward to our continued work as we move forward. Thanks.
Thank you. And Sarah, please just introduce yourself and if you would recognize any other staff members that the public needs to be familiar with.
Hello, I'm Sarah Stanton with the Division of Legislative Services. I've been staff to the Commission for all 7 years that we've been going. It's been an experience. I'm also the staff attorney for the Health, Welfare, and Institutions Committee. Numerous staff at Legislative Services have helped out with this over the years and continue to assist, so I couldn't do it without them. And we are here to help with whatever you need moving forward.
And you have been most helpful. I feel I'm in very good hands with you as staff. And with that, as Sarah and I talked about the reformation of this particular subcommittee, from being a committee that had focused on criminal justice diversion to a broader and more inclusive purview of all special populations, which include, of course, those that are in our criminal justice system, but is far broader than that. Sarah has brought together a very good overview of a number of these special population issues that may come before us. And with that, Sarah, I will turn the presentations now over to you for the first one, which is the update on services for special populations.
Yes, Madam Chair. Our first presentation will be Heidi Dix. She's the Deputy Commissioner for Compliance, Legislative Affairs, and Regulatory Affairs with the Department of Behavioral Health. And she is here with us and getting her PowerPoint ready to go. Second.
Good morning. Good, Senator Deeds, I just saw you in the purview. Welcome so much. And again, thank you so much for your leadership in this area. I know it is driven by so many factors, but it really has benefited from your dedication and expertise. Thank you.
Hello, everyone. I'm just trying to flip out of the, get to the right version so you all don't see my notes. So just bear with me. Just trying to, can you see my notes on the screen?
Yes,
okay.
We can.
Now, Sarah, I can't remember what we just.
And Heidi, I believe it was at the display settings where it was yes, up at the top.
Yeah.
Display settings. That's
got it. Got it. Thank you.
That's the one.
Sarah keeps us all straight. So thank you, Madam Chair and members of the work group for inviting me to speak with you today. I know the slide says Commissioner Land, and I'm standing in for her today. During this presentation, we'll cover some of the updates related to programming for 3 important populations that you requested an update on. So justice involved individuals, children, and the geriatric population. And as usual, it's DBHDS. We have a lot of slides, but I will try to move through things very quickly. If you have any questions, of course, I'm happy to take them. So jail-based services and jail diversion initiatives, just to reset for folks, because it's been a long time since we've met, DBHDS works on a number of initiatives designed to divert individuals with mental illness from the criminal justice systems when appropriate. referring folks to needed treatment, and ensuring those involved in the criminal justice system get the behavioral health care they need. This is done through jail diversion programs, forensic discharge planning, crisis intervention teams, which we often refer to as CIT assessment center sites, and mental health dockets. This is largely done in partnership with CSBs. So there's a lot on this slide. Again, we tried to cover a lot in a short amount of time. Jail diversion initiatives, including forensic discharge planning, work to identify individuals with serious mental illness and co-occurring disorders and divert them from the criminal justice system when it is appropriate, and certainly try to connect folks to needed services. CSBs are operating initiatives across the sequential intercept model, which I know many of you are familiar with given your background and also many of the discussions recently about Marcus Fuller and crisis response. So that's at the bottom of the slide. And we certainly offer programs across the entirety of that model. It really maps out the different points of an individual's involvement with the criminal justice system, from community services like crisis services, which is at intercept 0, which is really the most ideal place we want to engage with folks with serious mental illness, through court hearings, re-entry, and probation or parole. Last year, we served 3,749 individuals who were screened, and 1,296 individuals were enrolled in jail diversion and/or forensic discharge planning services in Virginia. The program costs roughly about $2,600 per person annually, and it pays for treatment, medication, and housing and more. And that just quite depends on the initiative, whether it's jail diversion or forensic discharge planning. The results really demonstrate the success of these programs. I know this was discussed earlier in the week in another work group. Individuals who are enrolled experience a 14% decrease in the use of emergency services or crisis services, and a 71% decrease in hospitalization. The total funding in FY21 for jail diversion was $3.3 million, and that went to the CSBs, and that included mental health jail diversion program funding, specific funding for rural jail diversion, and some docket funding, and I'll get into some of that a little bit later about the docket. Another busy slide. So crisis intervention teams, CIT, and the CIT assessment centers. This is another area that we have talked about in the work group in the past. DBHDS works on these two initiatives together, and they're certainly complementary. And we do that in collaboration with many agency partners, DCGS being the primary partner, but also others. And we really aim to give law enforcement officers training and tools that they need to interact with individuals with symptomatic behavioral health concerns and divert them. The CIT program is built through local coalitions of stakeholders from various disciplines, as you all know, including law enforcement, mental health, hospitals, individuals with lived experience, advocacy groups, and more. And it really seeks to enhance law enforcement capability to respond to situations involving individuals with symptomatic behavior. The most prevalent CIT model involves officers who have demonstrated experience, who self-select into receiving CIT training. It does differ from de-escalation training, and it focuses on preparing a subset of officers to address mental health crises. So you have sort of specialized law enforcement teams with enhanced training. All CSBs in Virginia have an actively involved CIT program. Some do not have capacity to conduct their own training. So we have two, those are Dickinson and Goochland, but they partner with neighboring programs. So we do have statewide implementation. DBHDS also receives annual funding to maintain the status of the CIT assessment sites. So the General Assembly has been very generous in their funding of these programs. There are currently 42 sites in Virginia. The average cost is about $323,000 annually for these sites. And so just as a reminder, they are locally driven, and so they have flexible hours, but they receive individuals who are in crisis. And the intent is to understand if the individual needs to be civilly committed and help them through that process, or help them in some other way. There was recently a work group that formed. It was in the 2019 time window, and I apologize, with the pandemic, things run together. And we put together a legislative report based on the work group. And their primary recommendation in looking at the CTACs was to look at developing 5 regional centers that were expanded. So they were able to operate essentially 24/7 and provide basic medical evaluation, but also immediate access to psychiatry. Most already have peer staffing, but inclusive of that, case management, 23-hour observation. So individuals could come in, and if they did not meet civil commitment criteria, they could still, stay in the CTAC and receive some services and support. And then there would be a warm handoff to the community service board or other folks to ensure people had the support they need in the community. Mental health docket.
Madam Chair.
Yes, Delegate Bell.
Is it your preference that we ask questions as we go or wait and take notes? It looks like it's going to be pretty long.
Okay. Ms. Dix, would it be all right if we ask questions as we go?
Okay.
Absolutely.
Go right ahead, Delegate Bell.
Ms. Dix, could you, or is it Dr. Dix? I don't want to.
Heidi.
That's fine.
Heidi.
Ms. Dix.
Thanks.
Heidi. Could you back up a screen? A slide. So can you maybe share how the CTAC is related to the crisis stabilization units? Because it sounds like it covers some of the same. My mental image was different than what you just described, which is fine. But that means I'm not sure I understand how those two interact, if they do, or in other words, if it was just an assessment place and then they, as quickly as they can, assign them, and the goal is to have a place that's open at 2 a.m. besides the jail. I can see that. I can see where that fits into everything, but it sounds like it also provides direct services, at least in the short term. Could you maybe tell us, do they similar, different, work together?
Sure. So there's a lot of variation, and I certainly can get you more specifics, but most of them are what you initially, your vision. So it's 2 a.m. and this is a place for people to go, and sort of a disposition can be determined. The police can drop them off, and then they that's it. I think what's envisioned is there could be a broader model that provides additional services so that people that are in crisis but may not meet commitment criteria get additional support and are able to sort of be supported in the community, so you don't see them coming back, in further escalation the next day. So it is a good question you asked about the crisis stabilization unit. I don't know that they are that related, but I can certainly check for you on that. I just don't know that off the top of my head.
Madam Chair, could I follow up?
Go right ahead and follow.
I guess I'll just say it. I'm not sure if it's a question, but if there's something that I'd appreciate any comments you have. So when we visited the CSUs at one point, and I think all of us came away pretty impressed. And it covers some of what you're describing, which is it's a place you can go before you, sort of as they described it, you're on the downhill slide and you can feel it, but before you have to be involuntarily committed, you could often voluntarily report and say, look, I'm really struggling here. Can you help me get my meds right? Give me 3 hots and a cot. Just it's a way to kind of, and it would seem to be part of the same continuum. Now, there they had to be assigned by the CSBs. That's how they would do the triaging, I guess.
Right.
And this sounds a little different. This is the opposite. This is the beginning of the triage, not the ending. And maybe in some ways it's the opposite of overlap. It's just what you need. I do think that the ongoing issues with the law enforcement have said we would be delighted to have another place and be delighted to take them there. We need to be able to hand them off and go. I'm 2 deputies in Orange are on duty after midnight. They're happy to go to the jail or go someplace else if that's available. Is this, you said 42, which sounds, well, that's many more than I would have thought if I guessed, but I guess it's still not built out. I mean, how much, are we a third of the way there? Is that just still a pilot project, really?
It's definitely not still a pilot project. I think 42, but what you would find is that there's a lot of variability. So they're not all open 24 hours. It's some of it's based on locally that I've identified, this is the time of day when we have a lot of people coming in, but it's not 9 to 5. And so we need extra support. but certainly there is a lot of variability. And there's also even variability about who's staffing and what's available between medical screening through consultation. So I think it's not so much expanding the number of sites as sort of looking at what's available and making sure everyone meets a certain minimum or floor.
Madam Chair, could I have one more? I won't.
Yes.
I promise I'll stop. This is such an interesting. One of the issues that seems fundamental, and it's nobody's fault, but just the fundamental would be that these are easier where there is density, just because the number of consumers is higher, and so it's not one person sitting around for 4 days waiting to see if someone comes in, but it's a steady run of people. Are there any of them that are trying them in smaller rural localities, or do you have some rural localities kind of combining? I mean, that Orange County deputy would be happy to go to green. He just doesn't want to drive 4 hours if he can. In other words, and maybe I'm just thinking through the rural lens, maybe Delegate Price would say they have the same issue in, Newport News or something, but I just, have you seen them be successful, or somebody trying it in a different, I don't know what that model would be, maybe an on-call, or the deputy calls when he's on the way and you meet at the same, the person's not sitting at the desk. Has anybody tried other things, or?
Yeah, and I do think that some of the programs are already rural programs, and I think there has been successful models in rural areas. I think what we've seen is, a lot of success when you get the local folks together. And so I do know that we have had it work in rural areas, and I can get you more specifics on the ones where we have them. But with 42 sites, we definitely have some in rural areas.
Cool. Thank you. Thank you, Madam Chair.
Yep.
And Heidi, I have both a follow-up comment to Delegate Bell's questions, as well as a specific question on a different added. Certainly when Fairfax County had not opened its center yet, but there were the plans and they were going ahead with construction. About 6-8 years ago, when I first started looking closely at Fairfax's situation, my reaction was, given all of the traffic and the fact that it might take an hour to get somebody from one end of the county to the other, meanwhile, there's all kinds of flashing headlights in their face and so on, that this would be traumatic transport. Couldn't we have substations? And one of the strong concerns in the mental health community is that the substation cannot have the attributes of a law enforcement establishment, because again, you're sending a different signal to the person who is in mental health crisis as to whether or not they feel they've been arrested or whether they are being taken for assessment. So even in the rural areas where distances are more of a problem than time is a problem for all of us, of how long the individual is sitting in a car in a traumatic setting prior to being able to get to an assessment site. So I know my concerns were summarily dismissed about 8 years ago. Let us put our resources into a single site that has follow-through capabilities. And then the other comment that I would make that I think is applicable throughout the Commonwealth is that the importance of this assessment was so high in law enforcement that the sheriff and deputy sheriffs volunteered to staff it so that law enforcement could get back on the street who had brought the individual in. It is an issue, and under the code, you have to have that formal presence of law enforcement with the individual. But I do think it's something that we need to look at resolving in a way that meets both needs because of the importance of that early assessment. And then just the quick question I have on the left side of the slide, you say there are 39 CIT programs across Virginia. Approximately what percentage of Commonwealth's population would be covered by law enforcement with CIT training?
I don't know the answer to that. all CSBs are actively involved. So I'm guessing it's mostly statewide, but we can get that to you.
Thank you so
Especially
much.
if it's presented, I'm not going to know that off the top of my head. Yeah.
All right. Thank you. Are there any other questions? Heidi, it's all yours again.
Thank you. Okay, mental health docket. So this is the last piece on the jail diversion criminal justice piece, and I will try to move quickly here. So DPHCS actually funds 4 mental health dockets: Roanoke, Salem, Stanton, Augusta, Arlington, and Richmond. And they divert eligible defendants with mental health disorders to community-based treatment. We have worked very closely with the Supreme Court of Virginia on the development of standards for specialty dockets, and we participate in the Behavioral Health Docket Advisory Committee appointed by the Chief Justice. These initiatives have demonstrated their success by helping individuals get the services they need out of the criminal justice system. Data from the first 2 dockets is what's shown on this slide. So there are 13 dockets total. So the Office of the Executive Secretary, they operate other dockets that are done independent of the funding we receive. So this data is from just our first 2 funded dockets, so Roanoke, Salem, and Stanton, Augusta, and they show that individuals are highly likely to obtain and maintain employment under this model and acquire housing over time. So it's a proven model. I think everyone knows that has worked, and with 13 of these dockets in the Commonwealth, we've seen great success. So now I'm going to move. There was a request to just get an update too on serving another special population, Virginia's youth. We are very committed to identifying strategies for alleviating the high census at the Commonwealth Center for Children and Adolescents, CCCA, which is in Stanton. That's our only state hospital for children with mental health conditions. We also want to really emphasize that we want to make sure kids are served in the least restrictive community-based setting that we can get for them, and work with all of our partners. We have a number of private provider partners in this space, as well as CSBs, to do prevention and early intervention. And I'll go quickly through this, but I just this is an important thing for everyone to understand. The pandemic is really, the behavioral health impacts are serious. We recently worked with the Medical Society of Virginia, and they conducted a survey of primary care providers serving children. Of the 150 survey respondents, 88% said that more of their patients are presenting with mental health symptoms since the pandemic began in March 2020 than prior. Close to 80% of the respondents said they are seeing anywhere from a slight to moderate increase up to 30% in mental health concerns in children and adolescents, including increased anxiety, depression, and behavioral issues, social isolation and loneliness, parental stress related to COVID-19, and access to child psychiatry services rank as the biggest mental health needs doctors are seeing in their patients. I don't think this is a surprise to anybody, but it just emphasizes that as things continue, the need for behavioral health support for children and adults is going to continue, and we're probably going to see a continued rise in the need over time, long after the pandemic's over.
Madam Chair, could I ask a question?
Yes, is that Senator Deeds?
Yeah, Heidi, how would you describe the department's relationship to the VCU facility, the VCU Children's Hospital out on Brook Road in Richmond?
The Treatment Center for Children?
Yes.
So we've definitely had a number of conversations with them. I know that they are seeing patients. I think also I'm going to talk a little bit about some of the conversations that we've been having with CHKD as it relates to CCCA, Children's Hospital of King's Daughter. So let me go to the next slide. CCCA admissions, I think there's a lot of detail on this slide also. The trends we're seeing there are very concerning. Without the COVID-19 drop in admissions that we saw in the spring, the 2020 numbers were likely to be the same or slightly higher than they were in fiscal year 19. We typically have a decrease in the census in the summer months, but CCCA is currently running at about 50% capacity. This is because we had to close the facility to admissions on September 9th due to a COVID outbreak. Compounding that outbreak, they're, quarantining staff and isolating them, we had a lower staff capacity. So we've been able to reopen. We reopened about a month later in early October, but we're operating on a limited basis. So staffing levels are improving. When we reopened, it was at 35% capacity. We're now at 50% capacity, and we have a number of efforts we're undertaking to recruit more staff. The 24 of the 48 beds are now open, and we're continuing to work with CCCA to increase staffing. We're watching our census changes closely because we often see a rise in census in the winter, and it becomes more difficult to maintain a therapeutic environment. Still, with our current needs, it's estimated that CCCA will need an additional 30 beds by FY 2022 to maintain its obligation as the facility of last resort.
Senator Deeds, you okay. Go right ahead, Heidi. Senator Deeds, did you have
sorry.
Yeah, it's always worried me that we just have the one children's hospital, and I really had hoped that we would be able to develop more of a relationship with the VCU facility, particularly since it involves a significant chunk of state dollars in its construction and running the hospital. Before we build more beds, I'd like to be able to build relationships with whether it's King's Daughters or VCU, and it ought to be VCU.
Yes, and so I think we have been having a lot more dialogue externally with many different private providers and entities to try to extend our reach. And so one of the primary things is last year, the General Assembly authorized us to do a report about putting together a memorandum of understanding with CHKD. So if they should proceed with building their new facility in the future, how would we be able to work with them to divert admissions from CCCA? We've had a number of conversations with them, very productive. The report about the MOU is due January 1st. There's a number of items in there, but one of the primary ones, 25% of the population we see at the Commonwealth Center is for children under age 14. And, it's challenging to serve kids in such a wide age array. And so we have talked with them extensively about perhaps taking some of those children. And that would be very helpful. The other thing we've done is we are working with Gateway Homes to take on a greater share of the 17-year-old male population. So we have a lot of those individuals, and we do have a contract with them to help divert or take individuals instead of them going to CCCA. Dr. Ward and Dr. Plaska are going to talk about behavioral health enhancement, but certainly there are a lot of proven tools that enhancement would provide, like multi-system therapy and functional family therapy to divert admissions for males under 14 with conduct disorder. And so, other states have been very successful using that model. There's also high fidelity wraparound to reduce recidivism, which we believe about 50% of readmissions. So these are things that we've been looking at as ideal for pilots and doing outreach with private providers. In addition, some looking to partner to do contracts with folks for residential placement as a step down, so kids are not sitting there waiting to leave. And we still have a critical need for children with developmental disabilities in the teen years. It's a very difficult population to support, and you have to do it the right way. And so that's another area where we're really trying to find some alternatives and partnerships. So we don't have all the answers, but we certainly have a very engaged group of stakeholders trying to work through this. One really engaged group, there's been two this year, was the Children's Inpatient Work Group. So we requested in last General Assembly some funding for children's inpatient services to divert kids from CCCA. And the General Assembly did provide that and has stayed in the budget. They also asked us to put together a work group, you all did. And we did put it together, and they did a number of things early on in the pandemic even to work through this. So we had a number of child-serving stakeholders to address the causes of the rising census. We had private providers. We had managed care organizations, CSBs, behavioral health advocacy groups, et cetera. The key findings from the work group was the need to invest in a comprehensive continuum. So to your point, Senator Deeds, not just additional inpatient beds. How can we avoid inpatient setting as much as feasible and keep kids in their home communities? And private hospitals need specialized programming and therapies to serve more adolescents presenting with aggression and or IDDD. So those were two of the main findings. If you look on the right side too, you'll see some of the specific results from a survey we did, including strategies the group thought would be most effective to divert admissions to CCCA and to increase step-down options. And so some of these things are woven into how we're going to be doing behavioral health enhancement, but there are also things where we're looking to increase our partnerships. There's also a children's residential work group that is wrapping up its work now, and that's looking more at the transition to residential care. We worked with agency partners on this, so it's not just a DBHDS, with kids, it's so many different agencies, DMAS, Office of Comprehensive, the Children's Services Office, CSA Office, DSS, DOE, as well as local CSA programs and the CSBs. The work group noted key areas where there were barriers, including timely placement, because there's a lack of collective understanding. Can people still hear me?
Yes.
Okay. Sorry, my screen froze. People found the system fragmenting, confusing, and difficult to navigate for youth and families, very time consuming, and it's very difficult to find a willing provider once treatment has been deemed medically necessary. So the overarching recommendations of the work group are on the right-hand side of the screen. They're really focused on aligning IACT and the FAPS process. So IACT is a process that's run by Medicaid. It's a medical determination process. Is the care medically necessary, the residential care? And then the FAPS process is, as you all know, a CSA approval process, and it's really looking at what's the most appropriate setting for the child with an emphasis on, community-based support. So there's a lot of training and education around this process that's very critical that the work group recommended to help families. Ultimately, the work group noted that treatment out of home, while sometimes necessary, should be seen as a last resort, and we need to continue investing in enhancement in STEP Virginia to divert folks from out-of-home placement. Before we move off kids, I did want to also just emphasize two other things. So STEP Virginia is an important tool along with behavioral health enhancement to help serve children and adolescents. And so we are, continuing. In fact, the commissioner right now is meeting with the CSBs about continued implementation of STEP Virginia. In particular, outpatient services and children's mobile crisis have helped CSBs add additional children's capacity, and will continue to do that. And we are in the process of creating statewide training for all children's mobile crisis teams over the next several months with a vendor. So we are continuing to work through these steps.
Heidi, before you continue, I have a question either for Senator Deeds or for you. As we have this subcommittee now on special populations, one of the things that I remember very clearly from the school crisis task force that the House had a couple of years ago was testimony, particularly in the Harrisburg area, about from school counselors that if we spot a serious problem, we don't really know where to go from there. That there's not a good linkage between the school counselor's role and those with serious mental therapy needs. So this is why I was directing it first to Senator Deeds. How is this handled within this joint committee?
The whole purpose, I think, of the reformulation of the subcommittee was to not take your eyes off the ball of jail diversion and the criminal justice, but to make sure that other issues and the children's issues were raised in Delegate Van Valkenburg's email of this past spring are what prompted I want to make, and Delegate Ransom, honestly, it's been for years telling me we need to focus more on children and focus more on prevention if possible. I want you all to develop some ideas, Delegate Watts. I'm hopeful that you all can develop the ideas to get the right linkage. You know, several years ago, Delegate Bell and I met with some kids in the area that we're honored to represent, and we produced legislation to create more of a mental health focused curriculum in the middle school years or lower high school years to raise awareness. But we need to make sure that the links between our school counselors and the links between our CSBs are strong for children's sake. We've got to make sure that people know where to go.
I really appreciate that guidance. Obviously, I think that is a very important link that we need to develop.
Madam Chair.
Yes, Delegate Price.
Thank you, Madam Chair. I just had a question to Ms. Heidi. As we're looking at the recommendations that are coming from the work group, because I'm new to the legislative versus executive, I just wanted to see, do you anticipate that some of this will be covered as much as possible within the governor's introduced caboose budget, or are these going to be things that we got information after that may have been and they need to be budget amendments? I'm just trying to see, you know, what legislative roles are there to some of these recommendations, because I also feel very behind the 8 ball because special session did last and we didn't have our meetings earlier. In effort of full disclosure, a lot of us are pushing up against our bill limits. And so I'm just trying to maximize how helpful can legislators be in this process as well.
That is a great question. I think we're all feeling a little bit squeezed because of this year. Certainly the governor's budget is going to be focused. I don't know what's going to be in it. But the budget proposals that we had put forward for consideration, of course, were focused on state hospital census initiatives. Overall, that's a crisis that we're having to deal with. And so certainly that's where we were very focused coming out of the special session. We did get a number of programs in the special session funding reallotted, like Step Virginia, VMAP, which I'm going to talk about next. And so we have a number of things, the Marcus Alert program, that we're going to be really working to implement sprinting, frankly, over the next year. So that was our main focus in some ways, is just moving forward with that. I don't know if that's helpful. There are a lot of recommendations in the work groups we have done, and I'm happy to follow up with you and show you all of those. We've done a couple briefings on it, but there was a lot of work we did this year.
Delegate Price, you have any follow-up? No.
Madam Chair.
Yes, Delegate Bell.
I think this is for Sarah. Sarah, we had talked about getting some information on the evolution of the TDT program. Is this when that's coming? And is it, this would be when I would ask about it, but I will wait if it's coming from her, Ms. Dix, or another speaker.
Yes, Delegate Bell, I think that may be something you want to hold for the next presentation.
Yeah, that's fine. That's fine. Thank you.
Heidi will still be with us, so we should be able to sort of group anybody we need to for that one.
That's great. Thank you.
Thank you.
And I am going to move quickly here. I know I've taken up a lot of time. Should I continue?
Yes, please.
Okay. So the VMAP program. So this is a program where the funding was, I believe, reallotted for us. And this is a really, really collaborative program that we have that's been highly successful. It's the Virginia Mental Health Access Program. We have a contract with the Medical Society of Virginia to administer it. And it's really about building capacity among our primary care providers to treat and respond to mental health conditions like anxiety, like depression, ADHD. Pediatricians can connect with regional VMAP teams, and they're made up of child and adolescent psychiatrists, psychologists, or social workers, and they really help extend the capacity of the mental health workforce by providing support to that primary care provider. And as of September 30th, and this is a relatively new program, there have been 426 consults with primary care providers, and intake calls, and 367 providers have registered with VMAP. And over 80% of the consultations resulted in pediatricians being able to continue treatment of their patients. So this has been a really highly successful program, and it's just really within the first year or two getting off the ground, and we've been really appreciative of the support. The next piece is the geriatric population, and I'm going to go quickly through here, but I think this is an important discussion. We came up on Monday as well in the work group. Our geriatric admissions have increased for 2020, even accounting with our temporary drop in April. We have geriatric beds at 4 of our hospitals. So Piedmont Geriatric Hospital, Eastern State, Catawba, and Southwest Virginia Mental Health Institute in Marion. And even before we had a couple of admissions holds due to the COVID pandemic, our geriatric units were operating over census. So we're well over 100% capacity in our units. And what happens when these beds are over census is the hospitals look for bed availability in the adult units, which reduces the capacity in the adult units. So we're constantly at the state hospitals, the staff are constantly having to adapt and readapt their space to accommodate admissions. The next slide is just gives you another snapshot. I'm not going to spend a lot of time on it. And just wrapping up here. So one of the significant challenges we face with the geriatric census is that many of the patients have a primary diagnosis of dementia. And Dr. Ward and Dr. Aplaska recently sat down and talked with us about the fact that our definition of mental illness in the code is outdated. And so those people actually screen in for civil commitment if they have a primary diagnosis of dementia. And so in the last 5 quarters, we've had 761 geriatric patients admitted to our state hospitals, and approximately 22%, so 169 folks, had a primary diagnosis of dementia at admission. And so these are folks that they have a primary diagnosis of dementia, and they're acting out in other ways that they're either at home or in a community nursing facility or other facility, and difficult to deal with, and they end up in our geriatric units. But dementia is not a mental illness, and assisted living or memory care is actually a more appropriate placement for these individuals. So we are looking very closely at this population and how we can support them better. As in Virginia, they're about 30% of our extraordinary barriers list, and the need is for assisted living facility care, nursing home care, or memory care. So this is an area that we're really trying to roll up our sleeves and tackle this coming year and think through. And just wrapping up, as you can see, state hospital census has been particularly challenged by COVID. That's not a surprise, and it remains a top priority for our system. And it's particularly urgent to address child and adolescent needs with just the Commonwealth Center, and also for our geriatric population. We know that the availability of services across the Commonwealth is critical to meeting the needs of Virginians and diverting folks from the criminal justice system as appropriate in order to reduce hospitalizations and inpatient care. So this is just a summary of a couple things we're doing, and I really appreciate your time today. And I thank you, Madam Chair and members of the work group.
Thank you very much, Heidi, and thank you very much for your professional dedication in these just couple of areas that you covered, and all those that work within the department. Are there any further questions before we turn to the next presentation? If not, Sarah, would you introduce the next speaker, please?
Yes, Delegate Watts. Our next speaker will be, we have a team on this one. This will be Dr. Ward from DMAS and also Dr. Aplaska from the Department of Behavioral Health. And they're going to walk you through an update on the behavioral health redesign and how it relates to services for children.
Hello, everyone. Thank you so much for having us here today to speak to you regarding the impact or potential impact of behavioral health enhancement on the special population of youth. I'm going to get the slideshow going and make sure that it works. I just want to make sure I'm having some difficulty. Okay, I am sharing that screen.
And Dr. Ward, we can.
Is that the trick? Did I do it?
Yes.
Okay, thank you. So actually, it feels like I have the wrong presentation. I apologize. I have two presentations open on my computer, and it opened the wrong one. The one that I will be previewing to our stakeholders tomorrow morning. So let me make sure that I share the right screen with you.
What they didn't teach us in school and which would be out of date even if they did.
No, this is not user error. There's something with Zoom where even though I'm selecting the right video or the right option out of my options, it keeps selecting the wrong presentation. So let me entirely shut down that other presentation to assure that it doesn't even give it as an option. And try again. Be patiently persistent with our platform. Okay. And switch settings. Do I have it now? Okay, it is the correct one. Thank you for your patience.
And Dr. Ward, if you
yes,
if you could go at the top of your screen where it says display settings, if you use that option, yep, and go that first option, swap presenter view, that will get rid of your notes section on the side. Yep, there you go.
Okay. So we were last with you with the full commission in August of this year to provide a general update about our progress in Medicaid during the COVID-19 pandemic, our response, and kind of the status of the Medicaid behavioral health funded system. Today, we're going to speak specifically to what sounds like you're interested in hearing about the special population of youth and how behavioral health enhancement is intended to impact that population. So as a reminder, the initial vision here for behavioral health enhancement was the development of a North Star. And so Dr. Aplaska and I have visited with you all, I've had the honor of visiting with you many times in the past to describe that North Star and the very large vision that we laid out almost 2 years ago now in our continuum document that we put out as an interagency document between DMAS and DBHDS, which spoke to all of the ways that we would seek to bring high quality, evidence-based, trauma-informed, and cost-effective services into a full, robust continuum for the Medicaid behavioral health benefit. What we're going to talk about today is kind of a reminder to everyone of how that relates to youth mental health services for the Commonwealth, and specifically to the priorities that were approved and are included in the budget for the current focus of behavioral health enhancement. One important piece of that, when we think about how this initiative ties into the needs of the Commonwealth's youth, is it really was inspired by and rooted in a lot of the good work that has already happened across the Commonwealth towards services for youth in other sectors. So that relates to the Family First Prevention Services Act implementation and how that seeks to provide behavioral health services to youth who are at risk of involvement in the foster care system. And then also very much inspired by the work done by the Department of Juvenile Justice and the transformation that they conducted, which moved toward an emphasis on evidence-based treatment and allowed them to move away from institutionalized settings and to even close one of their institutionalized settings because of the way that it allowed them to serve kids in the community and through these preventive services. So the ideas for enhancement are really rooted around things that benefit youth and family, and partly because one of the focuses of the development of that vision was on prevention and early intervention. So seeking to build out services that were going to take us into a focus earlier on in people's experience than rather the crisis orientation where our system finds itself today. And I hand it over to Dr. Plass to talk about those current priorities.
All right, I'm doing a sound check here. Making sure you all can hear me okay. All right. So we presented the larger overarching vision and North Star for our system to have a really seamless, multi-level system of care that really meets everyone's needs at the right place and the right time. But we of course know that we can't do all of those things all at the same time. So we recognize the need for a phased process that focuses on the system's most immediate needs. And so we know that our state hospitals are at capacity and that people are presenting in crisis. And so the highest levels of care really need to be built out to be able to divert from inpatient hospitalization. And so these 6 services aim to reflect that, and were chosen amongst that kind of larger continuum of care. So these enhancement services focus on high quality services with a lot of evidence that have been shown to work. So really great outcomes. Another reason why these were selected is that they currently exist in our system. So people are receiving them now, and we have a license for them here in Virginia for the most part, but they're either not covered or adequately funded by Medicaid. And so that really creates disparities in access, availability across the Commonwealth. So for example, those that are familiar with the ARTS program, PHP and IOP, or partial hospitalization and intensive outpatient programs, these exist in Medicaid for ARTS and have been shown to draw down costly ER visits and inpatient hospitalization. And so there's a workforce there, and the programs exist, but they don't have a rate and service definition to be able to also serve individuals who have primary mental health problems. And then there's also MST and FFT, multisystemic therapy and functional family therapy. These are evidence-based practice for high-risk youth. And they were really built out through the DJJ transformation, but again, also don't have a Medicaid rate. And so what happens in Virginia is that in order for a youth to receive these services, they would have to be primarily DJJ involved. And so we recognize that that's too late. That's after, the problems have already arose. There are a few kids that do access MST and FFT through FAP, but it, again, is not supported through the Medicaid rates. There's a rate there, it's just not sufficient to provide the type of care that MST and FFT provide. And then PACT, or Program of Assertive Community Treatment. This is basically a hospital without walls. They serve pretty severe individuals with severe mental illness. And this is primarily funded through general fund dollars and also at the local level because the rate that exists in the Medicaid space is insufficient. So these are a team of people that are available 24/7, meet people wherever they may be through their different levels of care, and have excellent data on showing the cost efficiency and driving down the need for hospital-based care. And then lastly, comprehensive crisis. For this part of enhancement, these bring on the Medicaid rates for the services recommended and kind of bring a number of large initiatives together. So enhancement is bringing on the rates for the services and system that's being developed through SEP Virginia, as well as that through the need to respond to the DOJ settlement agreement. So crisis really affects the entire population. And the Medicaid's rate here would reflect all the different levels of care. So it's almost like a mini enhancement of itself. It reflects a continuum of care within crisis, which includes a mobile crisis response. So that way we are diverting from emergency departments, community-based crisis stabilization, so crisis avoidance, so keeping people in their home and providing services to them, crisis stabilization units, so residential places where people may be admitted as an alternative to inpatient, and including 24-hour crisis beds. So sometimes the amount of time that you spend when you're presenting with an acute crisis that is kind of driven by a certain trigger, you need more than the 6 hours or the 8 hours to address that crisis, bring resources together, or you may be experiencing acute intoxication. And so those 23-hour beds are really critical to, again, avoiding inpatient hospitalization there. So this next slide is really just to kind of break down and reflect that for these 6 services in green, those are services that will that is intended for the entire population, regardless of age. And then for the maroon colored one, which is PACT, that's specifically targeted for adults with SMI. And then the blue services are specifically intended for youth.
And Dr. Plaska, I want to note that it says services for adults and adolescents are in blue. We wanted to acknowledge there that both of these treatments deeply involve the adult caregivers and natural supports in these youth's lives. So while the youth member, a youth age 11 to 18 is kind of the identified patient per se, their family is very integrally, I mean, the treatment doesn't occur without the self-identified family and supports. So they're also involved in the care.
Good point. So these are family-based services. And the target person is the youth. So. All right, next slide. So I was fortunate to lead the children's inpatient work group that Heidi had touched on in her previous presentation. And during that work group that we conducted earlier this year, we examined the state data that was available related to the population of youth at the Commonwealth Center for Children and Adolescents. And so this work group really wanted to better understand the demographics and type of care surrounding state hospital admission so that they could make more targeted recommendations for strategies and interventions that would better meet the needs of the youth. This also helped to identify the impact of recent changes to the service delivery system, namely the carve-in of behavioral health benefits into managed care. And so what was found is that the Medicaid admissions over the past 3 years, fiscal years, had increased from FY17 to 18, and then decreased in FY19 when behavioral health benefits became a managed care benefit. And some of the reasons for that were speculated is that now we have more of a coordinated effort, kind of holistically approaching the youth's care. So in the past, when it was a carve out, inpatient care and the CMHRS services or community-based mental health services were managed by 2 different entities, and they don't necessarily always speak to each other in real time. And this really allowed for improving care coordination around that. And so we thought that that was an interesting finding through this work group. We also found that CCCA serves as the first point of entry for inpatient psychiatric care for almost 3/4 of children covered by Medicaid. So for all Medicaid youth that experience an inpatient psychiatric stay, CCCA was their first point of entry for inpatient care. So as compared to non-Medicaid covered kids, you would typically be served in your local private community hospitals, but that wasn't necessarily true here. And then after admission to CCCA, only 15% had a subsequent admission to another inpatient facility. And why this was asked is because what was being reported from our CCCA colleagues is that once you're sort of labeled as a state hospital admission, it is less likely for you to be admitted back into the community setting. Because state hospitalization for some people really reflects that your needs are higher than what can be managed in other settings, which may or may not be true, but it is a finding of the work group. And then the other couple points that were made was we also looked at the admission data, the day of admission, and the type of services that the person was receiving, the youth was receiving on the day of admission, and found that other providers, intensive in-home therapy and behavioral therapy particularly, were providing crisis service. And that's really not what they're intended to do. These are stabilization services or long-term services. And so in the absence of a fully developed comprehensive crisis system for children, our providers were just doing the best that they could because that's all that they had in their toolbox to provide at that time. And then behavioral therapy. So we also looked at the comparison of kids for our CCCA, being admitted to CCA versus kids, Medicaid kids going into other private hospitals, and behavioral therapy was most commonly utilized for children admitted to CCCA. And so that's important because it reflects the population that behavioral therapy is intended to serve, which are kids with intellectual and developmental disabilities. And so we saw that data as well from Heidi's slides also. Next slide. And then just from a demographic standpoint, because we are talking about special populations, we looked at the breakdown for gender, race, and ethnicity. So 64% of the kids at CCCA are males. And so Heidi had noted that 25% of kids are under 14, but that 17-year-old group that we are partnering with Gateway to transition 17-year-old males to, those actually make up another 25% of youth at CCCA. And then in terms of our racial ethnic diversity and at CCCA served, so 39% were identified as Black, African American, 57% white, and then 1% each for American Indian, Asian, other, and then unknown. And so in comparison to our state level data, we know that only 19% of Virginia's youth are identified as African American, which reflects a disparity in who is being referred to state hospital care. And so I really, wanted to take a look and as part of enhancement, not just being accessible, but also equitable in terms of an outcome that we, aim to see through enhancing the services.
So I'm going to provide now a bit of narrative about how all of these pieces fit together and how we see these services impacting the current service system and the youth that participate in that system. I personally am going to give everyone just a small disclaimer that virtual school just released inside this home. And so there are numerous children here who would enter this room, and we hope that they will not. So just how life is right now. I want to start with multisystemic therapy and functional family therapy, because these are our two heavy hitter services for this youth-focused conversation today. So our hope with behavioral health enhancement, beyond hope, our scientific hypothesis would be that by making these services more accessible to our members, that this would provide an alternative treatment option for kids, much like those who traditionally end up at CCCA, who end up in higher levels of care, who often have multiple courses of care. And those are the kids for whom these services are intended and for whom they've been shown to demonstrate great value across other state implementations, significantly reducing the need for inpatient and significantly reducing the need for residential care for kids who fit, kind of fit the target population there. It is also a potential service for some of that subset of kids who may have traditionally been served in the community in intensive in-home or in therapeutic day treatment service. And I know that Delegate Bell has some questions about that today. I don't know that we'll be able to attend to the full scope of your questions, Delegate, but I'm happy to talk about that as much as we can today. But we do believe that there will be kind of a subpopulation within those traditional community mental health and rehab services, which would be able to, in this case, rather be served by MST and FFT. And it would provide an alternative for them, an enhanced service. So it's not necessarily taking away those services, it's providing an alternative. PHP, IOP play the same role, to be honest, in a very similar way, because for example, therapeutic day treatment is really a day treatment program. And what are partial hospitalization and intensive outpatient programs? They are numerous hours of the day. The difference between these services, though, is rather stark in the way that we're implementing them, because PHP and IOP, the way that we're implementing them through behavioral health enhancement, has a lot more structure and a rate set specific to a very licensed and clinically driven team that includes QMHPs, but that is, particularly in the case of PHP, physician driven. And these are generally known to be shorter term, intensive, very goal-oriented services where kids and teenagers would be able to go to get, a really strong comprehensive assessment, medication management. Sorry, reset is happening right now in the post-school, if you can hear it. I will try not to be distracted by that. So it's going to provide these intensive kind of step-down opportunities. So intensive outpatient programs might actually be a good choice for some kids who might get intensive in-home or TDT, where there might be a specialty program of intensive outpatient where they could get, instead of the longer courses of care that we see in TDT, this might provide for some of them a shorter term alternative that was very focused and symptom focused on the child's needs. These could also potentially even happen in partnership with schools, these intensive outpatient programs. And partial hospitalization is, that kind of diversion from inpatient and CCCA type placements, even resident placements, diversion from that shorter term that could step down into IOP, that could then step down into traditional outpatient care. So you kind of go from being all day somewhere to just a few hours of the day to then just a few hours over the course of a week with an outpatient therapist. So and this has been missing for children outside the substance use benefit. So the goal here is to provide these alternate kind of intensive, clinically focused programs for youth. And I think, really the biggest potential we have here, as Dr. Aplika has alluded to, is in the reform and enhancement of our system. Because I want to go back to the anecdote that Watts started with counselors in school and, not kind of knowing how to navigate or how to enter a youth into the right door of the help they need. A conversation I had a lot with different schools and folks across the system is examples of kids are in school and there is a suicidal crisis or a self-harm crisis. One of the things that expanding our mobile crisis benefit is going to do is to allow for greater mobile crisis, which could also go into the school. The school would also be able to call mobile crisis for their community and have them come into the school to serve that youth. And we just really don't have the availability services at a robust level that allows schools that kind of access to in-the-minute crisis services. That pairs with, so part of the key comprehensive crisis system that we have designed and funding has been restored is really building up, helps to build those doors. So say, we're going to go with the story here. Say a kid is in school, they're having a suicidal crisis, they're with their counselor. The counselor calls mobile crisis, and they're looking for services in the community, maybe not services that are directly in the school. The mobile crisis event, if they can't find an immediate referral for the family, there is what we are calling community stabilization, where a team stays with that kid and family until the opening comes up. The opening is in with an intensive in-home provider, but they can't do a warm handoff the same day. This new service provides they kind of hold the hand. They're like holding the warm hand until they can hand it off 2 weeks, however many weeks later, to the longer term community-based provider. Or it could be an IPHP program that's really tailored to this kid's depression, for example, since I know we're going to be seeing a lot of that. So maybe they're waiting for this great opening to happen in a program, and they're going to have that kind of warm handoff. Or if they need more intensive residential crisis stabilization, they could take that kid unit for care or for 23-hour observation. So the idea is to really build out a full evidence-based crisis system, like many states are underway and trying to do nationally, to really come in line with what we have been shown in other states like Arizona to do, that kind of improves the way that people access these services, that diverts from hospitalization. Arizona has shown most recently in their preliminary data that I just saw on a national call a few weeks ago, analysis showing, this was just for adult analysis, but showing that 50% of their Medicaid members were served entirely through crisis. So the crisis was resolved through mobile crisis, and that was the only contact that was necessary. And they also have that broken out in that analysis, which they're publishing, that goes through what proportion needed more than mobile crisis and the other services, and how that is kind of preventing reentry. So kind of leaving the ER and going back in that open door. So you go to the ER, you might be stabilized, go home, end up back in the ER the next day. A system like this is meant to prevent that for kids and families. And I think that's particularly important for kids and families, and keeping them, in their communities, keeping kids from having places like CCCA that are so far away from their home, and then making church plans is so very difficult. Having families stay and be able to be involved in care planning is so, their natural supports in their communities at home is so important. And I really believe that mobile crisis is a huge key to doing that for our youth and families. So that is my narrative there on comprehensive crisis. I want to just take a moment to acknowledge, while funding was reinstated for the second year of behavioral health enhancement in terms of the Medicaid rates and services, the DBHDS side of this budget was not reinstated for the training. And so I just want to put the perspective on this, that while we will be able to open up these rates and we will be able to allow people to begin billing for these services, and while DBHDS is being very creative and are great partners around trying to find ways to fund some training, and when we're talking about improving the workforce, which is, I know, a theme of this commission and things that come up again and again, it takes resource to build a workforce. It takes resource to take providers who are not trained in MST and FFT to get there to the point that they're at fidelity and they can offer these services in the way that's intended and in the way that we then expect to see the value and outcomes. And for a single functional family therapy team, that costs about $29,000 to train that team in startup costs. It costs about $22,000 to do that in multisystemic therapy, because there is intensive training and supervision and national oversight and credentialing. And so our ability to impact youth, will be reflected of the resources that we have during this really strained time. That's just the reality of it. But we do have some providers that do already exist in the system that will be able to step up and get us started. And, you know, our hope all along has just been to get our foot in the door and to get some of these services started and to test this and see what outcomes we can bring to all of our stakeholders and members that will hopefully help improve their lives. So that is the slide deck that I have, but I'm happy to answer questions.
Thank you very much, Dr. Ward. Are there questions of Dr. Ward or Dr. Aplaska?
Madam Chair, I don't want to be the only one asking questions, but I have several about the TDT program.
Proceed.
Okay. Yeah. Again, is it Dr. Ward? I want to give you your proper. Mm-hmm. Okay, Doctor. So Senator Deeds and I had a conversation with somebody from your shop, and my recollection is it was earlier this year, early spring, like February. That might be wrong. Might actually have been now that I'm thinking about before the new year, and it was about the significant drop in population for the TDT program. And I don't recall if you were on that call, but it was sort of a you all appeared to be addressing an issue which wasn't the one we were raising, which is the provider side. And you had reasons you wanted to reduce the number of providers. You clearly thought that some of them were not good providers of services. We were coming at it from the consumer side or the population side or the child side or whatever you want to call it. At the time, there had been a significant drop off in served kids, and there was projections for an even greater drop coming into 2020. Now, COVID makes a mess of year-to-year comparisons, but the feedback we received from you all, and I received feedback thereafter, was that you thought you were going to give the services through a different method. It would be a better method, and that was certainly not what they were seeing at the tip of the spear at the services end. And I'd like to get some feedback on, you know, have the numbers stabilized? Are we now serving the same number of kids through a different method? If we're serving a smaller number of kids, what does that mean? I don't have any new news from our local CSB, but I plan to follow up as soon as we get whatever feedback you have. But last time, what they were telling us was very different from the bottom up than what we were receiving from the top down. I would appreciate any comments that you have.
Oh, thank you for that question, Delegate Bell. So I do remember a conversation that I had with you and Senator Deeds over the phone. So I want to make sure we're referencing the right conversations and who was involved with them. And in particular, I want to be sure of that because we have done analysis on the aggregate around the time period of the provider terminations that you mentioned. So I want to note several things. One, our analysis showed during that time period that while we know that there were provider concerns and those came in through a number of venues and sometimes through your office, that there was a reduction. People were experiencing concern about a reduction in therapeutic day treatment services. What we saw consistently throughout that period on the aggregate was actually more children were served than ever before in therapeutic day treatment. I think what the disconnect that was happening when we look at 10,000 feet about number of children served and what individual providers were experiencing was an artifact of more children overall being served than ever before, but the service authorizations being reduced. So perhaps each child getting less service than they had had before. Some services certainly, I'm sure, were denied. That isn't part of the managed care process. But what I can tell you from the aggregate data that I have seen, the kids during that time period did not decline overall. In fact, that we served more Medicaid members in TDT than ever before, and there was a stability around the total number served. There is greater subtlety in that service authorization data, and I'm not at liberty to, provide anything concrete on that at this time. But I have seen those other numbers, so I can tell you what I've seen there.
So
I can also say that in terms, yeah, go ahead.
I just I mean, I pulled up the newspaper article that prompted this, and they had a roughly 30% drop in kids served through Region 10. Now, that was a combination of the previous number and then the projected. So I don't want to, I'm not coming at this with figures from them, but would they, I mean, you're right. They said you had kids that had been approved for years that got cut off. You had kids that had been approved for much more extensive services that were getting such a small amount, it may as well not be any. And then they were getting the aggregate total of kids that were being served was being reduced. And what you told us at the time was that there were other programs that were coming to take the place and do it better. And I'm not saying that's not a good long-term goal, but what I think we left the phone call feeling that until those new safety nets are in place, it felt as if this one was being jerked away. Now, if you're saying that that's just not accurate, I'll go back to the CSB. But the last time we did this, this feels like a replay of a conversation we had before, which was we didn't care about the number of providers. If you're culling bad providers, that's a great thing. I'm not saying that that's not a good role for DMAS, but we were coming at it directly from the schools that were saying the kids who had been approved previous years suddenly are being cut off, and we have no other way to give them services. And by definition, the TDT kids were kids that exceed our ability to provide through the counselor. I mean, basically, the counselor said, I've identified a kid. I know what he needs. Last year he would have gotten it. This year he doesn't. And now, again, I don't. If you disagree with that, then I need to just go back to the CSB and see if they've seen a very different change than what they told us about in February. But
so what I will say is that this is a complicated issue that can't be answered in a few sentences here at this time, because the impacts of what have happened to TDT over the last 2 years are, I think there's been a misattribution in the system of what has happened in TDT as being somehow connected to behavioral health enhancement or intentions around, like you're saying, bringing in, which is true. We do hope to bring in other services. It wouldn't make sense for us to direct anyone to reduce services before those new services are online. The reality, I think, of what is happening, I can say this as a hypothesis, is managed care in our system started kind of full blast implementation during that same period. And part of the function of managed care is to look at each case with a really careful eye and a wider lens than we had before in fee-for-service, because they're looking at the full medical history of the child, the physician records, the pharmacy records. They have a different process than goes on in fee-for-service. And so as the managed care companies started looking at these services and looking at appropriateness of the service and different options for the service, those activities conducted by the managed care companies, which are our contractors, is a separate process from the enhancement process, and one that I can't speak to super directly in this moment because it's really, I just can't. But I want to note that I think that it's been very difficult for the system to have these things happening at once, because I understand why there's confusion about what is influencing these different impacts. And I do believe that those are impacts related to managed care, managing the services, and not about behavioral health enhancement being too slow to bring, not that you're saying that, but that the other services aren't online yet.
okay, I'm not sure I'm following. So if it isn't, are you saying the services are there and the MCO is not approving? Is that so teacher says kids.
Well, no, what I'm saying is the managed care companies are having this more intensive lens on each child and the authorization for that service. And so they're making decisions with a wider lens than a fee-for-service decision would have been made. And so, there's just a different lens applied in managed care when you're approving healthcare services. And so there have been changes we have seen in terms of how managed care has approached those services. I want to also mention, within the context of this problem and why it's so layered and it's really sticky to get into, is that a problem that COVID has really revealed and kind of brought to the fore around therapeutic day treatment is that there are some critical issues about the way that treatment is set up, the rate and unit structure of that treatment, which have implications for the inflexibility of the business model and the way that the treatment is developed. And I know that was like a whole bunch of words, but what I'm trying to say, like in plain spoken language, is when COVID hit and you couldn't be in school and you couldn't do groups, and TDT is a group service and it's done in schools, that really created a lot of problems. And we tried to allow the most flexibility that we could. We said, okay, you can offer it not in groups. You can do it individually. You can do it telehealth. You can do it any way you can do it, which is not how the service is set up. But it only helped them so much, because if they offer it that way, because the rate is structured to be a group delivery, so the rate's lower because you're supposed to be seeing numerous kids at once, which bolsters the hourly rate for conducting the service. If that's not the way you can do it, it suddenly makes it really hard to stay financially viable. I would put out there that, and this is a hypothesis and a question, not a true answer, but I wonder about how those rate and unit structure issues with that service impacted the model under MCO action. That if you had a whole lot of kids approved for the service and then less of the kids were approved, you're making less money on the service. And in the way that structure was set up, I can see how that was impacting people's business models and having them throw up their hands and say, I can't afford to carry this service anymore. I need essentially, the business model is built on having a certain number of kids qualify for the service because it's a group-based service. And if I don't have that number of kids, it creates some hardship in figuring out how to pay the cost of the service. Is this making sense?
It does. It's just, but it's very, if you don't know, who would know? I mean, that's an interesting hypothesis. It might be true. It may be that we've driven out some lower cost providers. On the other hand, you might have kids that just didn't access services at all because the teacher didn't see them and their parents were not able to. I guess, I mean, can you give us the numbers of, I don't know, your population each month that are accessing these services from looking back? So it was October 2019. This all kind of, so it'd be, I mean, can you give us those, back at that up 5 months and just show us the population? And if you want to show us a substitute service, we would like that.
I'm sure we could. I mean, obviously I can't right now, but I could ask.
I'm not trying to put you on the spot, but I mean, okay. Madam Chair, I've taken up enough time. I would definitely want to see these numbers. And, here we head into the second session where I'm not sure I understand how these kids who were previously getting services are now being served. And so I would ask that we get those numbers before the January session if we can. I realize it's December 10th. Thank you.
Thank you, Delegate Bell. And yes, it did take a little bit of time, but I do think that what you were pursuing, is it something systemic or is it something that's COVID driven as far as the payment model and so on, and what we are going to have to do. So yes, follow up on those numbers would help us untangle this as to whether or not this is going to be an ongoing systemic issue.
Chair.
Sarah, I'm looking at my screen, which is why.
Madam Chair.
Yeah. Okay. Yes. It's interesting when you're not live. If I was live, then you'd know what I was doing. But Sarah, next one on the agenda, if you would introduce, and thank you very
Madam
much
Chair.
for the presentation from DMAX.
And I believe Delegate Price has a question.
I'm sorry. Yes, see you, Delegate Price.
No problem. Thank you. I respected the conversation, Madam Chair. I respected the conversation that Delegate Bell was having, ended up in a business model conversation. But something that was said, I want to make sure I heard correctly. Did I hear that more children were being served, but with fewer services? And if that is correct, then what is the strategy for us to get to more children served with all of the services that they need?
So services within Medicaid are based on medical necessity. And what that means is that really is supposed to be consumer driven. That is not just supposed to be, how do I say this? It's supposed to mean that if I need mental health care, that whatever needs that I have should be based on my needs alone, not like what my brother needs or not what was good for my mother. It should be based on my medical necessity and my impairment. And so those are how the decisions are made. They're made individually. And because these community mental health and rehab services, specifically ones like TDT, are based on a unit system, you know, a single unit is up to 3 hours a day. And so, you know, if you put in an authorization and say, this is a child and they have these problems, the predominant problem in therapeutic day treatment is attention deficit disorder. This child has attention deficit disorder, and so we believe that they need to be in a group treatment for attention deficit disorder, and we would like 2 units a day. We would like 6 hours of treatment a day, every day, you know, for many months. What we're talking about is because it spans of these units, the MCO might say to them, you're approved for 3 hours a day of treatment, you know, and let's see how that goes. It seems like in our clinical assessment of what you've provided about this child's story, that should be sufficient to care for this child. And if it's not, come back to us. Or in some cases, when a denial happens, it's because whatever they present, they say, you know what, this isn't the right treatment for this kid. For example, in the case of ADHD, they might say, this kid's never been evaluated for medication, or we've identified in our network, we have this specific program, this family-based program for behavior management of TDT or of ADHD, and we'd like to match you with this other provider who we think could have a lot of benefit for this kid. And so they might refer the family to a different service. They might make a judgment based on what that individual kid needs. And so when I say there are more children served than ever, and there are less services, meaning that less services means there's less hours. That's probably how that has happened, is they're able to serve more with, you know, granting less hours of service over time. Now, and I just want to put out contextually, and I wouldn't feel so confident saying this if I wasn't a licensed clinical psychologist. These are extremely intensive services of many, many hours a week. And so there is some room for variability in there when we're working within, you know, a wide range of available time to be with that child and to serve their needs. Because it's not like a quick on and off switch, like I'm getting an hour of outpatient therapy a week and then suddenly I'm not, or I'm suddenly not given any services, or I'm told I can only be seen once a month. You know, it's a wider flow. So there are more kids served and less. This is all hypothetical, I'm saying, because I can't provide that service authorization data. But we're hearing that, you know, that service authorizations are less, but we are seeing on the aggregate that more kids are being served. And, you know, and the frank answer to how we get to more services and more kids served is more Medicaid expenditures, you know, is more services, you know, covering more different problems and more variety. I mean, that's the consequence. It's like more services, more money. And so there's always a balance in healthcare, I think, going on a limb here, but there's always a balance in healthcare of providing the right service at the right time, you know, and something that is really medically necessary for the kid, and identifying what other things may be outside what is medically necessary to help support that kid in their life.
And Madam Chair, just one follow-up.
Because behavioral health service.
And so that the definition of medically necessary is what you're saying, that the insurance company determines, not the private provider that's working with. Okay. All right. Thank you.
So this
That's
then
right.
is part of the major problem of moving to managed care. I assume that tracking is the same problem for many different types of services, not just mental health services for children.
That's right. That's right. If we had healthcare in here right now talking about it, they would be saying a very similar story. I mean, that's the nature of managed care, is to manage the care, to look more closely at the care, you know, to find innovative ways to deliver the care, to increase value and quality, you know, to incentivize providers to do unique and innovative treatments that show outcomes. You know, that's really the goal there, is to manage the care towards what's going to give us the best outcomes and best health for the member.
Thank you very much. Are there other questions? If not, again, thank you so much for this presentation.
Yeah, thank you for having me.
Thank you.
Thank you.
Yes, Sarah, the next agenda item.
Yes, our next agenda item is an update, some additional information about mental health services for children in the Commonwealth. Emily Griffey, the Chief Policy Officer with Voices for Virginia Children, will present, and I'm going to operate her slides. So we're going to see if I can actually do this. Share my screen real quick.
Thank you for having me speak today, and thank you for operating the slides there, Sarah. I am the Chief Policy Officer at Voices for Virginia's Children, and my background is not particularly in mental health. So I wear a wider lens in this conversation with an overall picture of children's health and well-being. I'm also a shift from your previous presentations. I only have 10 slides, won't take a whole lot of time. And I come from the perspective of an advocate, where I get to dream about the way things can change and improve. And that's what I want to bring to this conversation today. I want us to come out of the pandemic and move forward operating under the assumption that we don't want to return to the way that things always were. We want to build a better system for our children. And we need to focus on realigning and reimagining the systems that we have right now so that they prevent trauma from occurring. And then they build our whole child well-being into our orientation, to our health system, our mental health, our early care, our K-12, and all the groups that support the professionals in those spaces. Sarah, you can go to the next slide. I think children's mental health is facing a critical systems change moment right now. How do we fund and restore those services that we're talking about right now, those critical things that DEHDS and DMAS has presented, while we're still faced with even greater needs? And then how do we do that within the context of community and racial trauma that we know is a dual pandemic in our culture right now? And how do we do that while casting a wide net to ensure that all parts of our child serving systems are oriented to supporting mental health rather than just focusing on those with the most severe needs or the older youth in our system? Next slide, please. So before the pandemic, we're home to the Kids Count Data Center at Voices, and our statistic is that 1 in 4 children in Virginia have experienced mental health issues that range from ADD to depression and anxiety. And so we don't have an exact post-pandemic comparison point for that yet, but we do know that, of course, because we're not quite there yet, where we'll be. But we do know that looking during the pandemic, the Mental Health America online screening tool saw a 93% increase in folks looking at using that tool over 2019. And of all the increase in individuals seeking online screening for their mental wellness, there was a 9% increase among youth 11 to 17. We know from previous research that community disasters or trauma produce high levels of mental health in children, with as many as half of children in a community experiencing an additional mental health issue after a disaster. So next slide, please. So we know kids experience mental health issues for a variety of reasons, from the biochemical issues in terms of brain functioning to other health impacts, as well as their personal experiences. Some personal experiences that can produce mental health or social emotional wellness in kids are considered traumas or adverse childhood experiences. These experiences are defined as witnessing violence or experiencing family disruption that could be the result of death, incarceration, or divorce. It could be from experiencing financial hardship or experiencing racial, cultural, or historical trauma. During the pandemic, we think all children were experiencing a level of trauma. They were experiencing grief and loss. The way of life for children dramatically disrupted when schools and child care programs closed on a dime in March. Families experienced more economic hardship, and we know this trauma disproportionately impacted children of color who were already experiencing the pandemic of racism in our country. So you, as legislators leading on the mental health system, have the chance to pick up the net and cast it wide to meet the mental health challenges for children within the context that they live, within their families and in their communities. I hope that your role in playing a leadership role on mental health in the system will be asking about mental health in every other committee you sit on, around education or health, commerce. Make sure that there is a question about how are mental health services applied and addressed. And as you consider your budget and legislation priorities, Sarah, I have a few ideas, 5 ideas for you leading into session. The first one, if you switch to the next slide, thank you. The first one is to support parents. During the pandemic, 1 in 5 parents reported feeling stressed or depressed. A parent's mental health is directly related to their child's mental health and wellness. Parents who are stressed financially or by grief or loss can't provide that optimal supportive environment for their young children's growth and development. So policies that can support parents, such as expansion of the home visiting or paid leave, are particular ways that our policies can address the role of parents in our society and in our culture. Next slide, please. Other place to start is to start early, in early childhood settings and in elementary schools. You can do this by training early educators to support social emotional wellness and to address mental health appropriately. Delegate Sickles on this committee as well sponsored a study this year to look at expanding early childhood mental health consultation models that the Department of Education did. And so we hope that as they've looked at how to do that, that you will also support continuing to expand those models across systems of mental health, DBHDS, and education. And so this is one area where mental health in the early years looks a little bit different than it does later on. And it can often look like behavior issues. And so what we hope is that right now, children have been disrupted. They've been out of childcare. They've been out of school. And their families are experiencing these traumas. I don't know if we'll go back to a place where schools and classrooms will look normal after the pandemic. Social emotional wellness needs to be baked into all of our approaches to returning to the classroom in the future. And how can we build that into BPI, childcare, mixed delivery, our basic school funding formulas to make sure that a mental health component is included moving forward and that we can fund those services. The third area, you heard a lot today about Medicaid. And so we also see this from the other side of the coin. We've talked a lot today about how to rearrange some of those services in Medicaid and what it funds. We also see there's lots of opportunities in Medicaid if we choose to leverage it in this way. One thing in Virginia is that 1 in 3 children are recipients of Medicaid are famous right now. And so we can reach 1 out of every 3 kids, those most vulnerable kids economically and that are facing the social determinants of health in Virginia, if we pay our attention to that population that is enrolled in Medicaid right now. And some ways that we might explore doing that is looking at incentivizing additional screening to find out what mental health issues children are facing and fund that screening through Medicaid. We can look at additional care coordination and some innovative health responses that we talked about today, those evidence-based practices as well. Fourth area is to continue to build the continuum. And we've talked about the BMAS areas and the DBHDS areas of the continuum today. I'm taking an even bigger sort of picture of the continuum that then looks at schools and families and the other pieces as well. On this slide, it looks like an arrow, but I really think in reality, it's probably a broken arrow and that there's gaps in the system based on where you live in different parts of the state and how much of these services can be provided. So I think we just need to have more conversations across different sectors about what this continuum looks like and how we can put in accountability across the system to get us to a place where we can straighten out this arrow and build this arrow, and what public-private partnerships are in place to be able to do that as well. Since we have a number of ways to build that together. We at Voices have been advocating for establishing a permanent children's cabinet and see that having that cross-sector, cross-agency approach could be a really critical step to providing that accountability and leadership to help straighten out this continuum. And fifth, and finally, and most important, is to apply an equity lens to all of this work. You know, in order to build back better in these systems, we need a workforce that is trained and prepared to meet the needs and respond to racial and historical trauma. We need to ensure that the workforce is trained in implicit bias and the intersection of racial and historical trauma. And we need to recruit a diverse array of mental health professionals that are more reflective of the kids that they serve. So finally, we've called to elevate the prominence of kids issues by making that children's cabinet permanent with a fully funded and dedicated staff. We think that that's the interagency approach to really elevating child well-being in Virginia. I often get asked the question, are kids okay right now? And I think we can just frankly say they are not. And it's going to be hard to ensure that they are moving forward unless we all see it as our job to support mental health and well-being in each of these areas that kids and families are. And prioritize kids and families in the decisions that you all make as legislators. So I hope going into this session that you will consider children's mental health, children's social emotional well-being as a fundamental question to where you start from and how we respond to this pandemic and how we're going to ensure that our kids have a strong future in Virginia. Thank you.
Thank you very much, Emily. I particularly appreciate the good, solid titles to each one of your slides so that the message was very clear on focus in these areas that all have to be addressed. Are there questions or other comments? Let me just then say two things about your presentation. One was on the parental support. I would just highlight that given COVID and given its effect on women in the workforce, and both either some have been able to choose to leave the workforce if they are in a two-parent family, but there are many, many who have been forced out of the workforce, who are single parents, and all of the ACEs are just multiplied for the children in those families, and the difference in support that is really required for the two different circumstances of two-parent and single-parent families so heavily hit by a recession that has hit women more than it has men, particularly in low-income service jobs. And then the other thing that I would also just throw out is that without going into why I make this observation, over the years, I've been very impressed with those studies that show the strength of peer group relationships towards healthy emotional development, and that in the closure of our schools, months upon months upon months, while I am deeply concerned about the education gap that this is creating, I'm also concerned that we may have added long-term problems because of the problems with emotional development that this essentially 12 months without those kinds of peer group interactions are creating. Is there anything else? Then Sarah, you're on. Thank you for introducing our next speaker.
Okay, and our last sort of presentation of the day, we have Dr. Richard Bonney with the Institute of Law, Psychiatry, and Public Policy, and also Heather Zell. They are here to talk about a proposal that would sort of link the collection of data around mental health and criminal justice, and I'm going to let them explain that. They'll do a much better job than I will.
Me unmute myself. Well, I know you have all had a long day, and but you're doing God's work, of course, and good luck to all of you. So I'll try to, I think I can keep this to about 10 to 15 minutes and convey why I'm here. What I want to do is explain why we need an ongoing cumulative database that connects mental health data and then criminal justice data relating to involvement in the systems and outcomes to the extent that they're in the administrative databases that already exist. And then offer a plan. I think this is feasible to do this, and offer a plan for creating such a database. The specific ask here is a Section 1 bill. I've given some possible language for it that would
interrupt for a moment.
Yeah.
Sarah, do members of the committee have a draft in front of them on this Section 1 bill?
Madam Chair, it's not a DLS produced draft, but there was a document that was attached to the email I sent out about 11:30-ish that does include 2 Word documents. The first is the Section 1 bill draft that Dr. Bonnie has referenced, and there's a second document that has a piece that would go along with that. So you,
so that if the members do have access to that draft, it might help follow what Professor Bonnie is laying out.
Yes, I think, although it's got some technical stuff in it that I'm not going to get, very
right. Of course, right.
Yeah. Okay. And I need help with regard to the draft if the work group is so inclined to move forward with this. Basically, knowing, I know what the economic situation is, of course, and what I would like is to convince you and the General Assembly that this is worth looking into, and to do a feasibility study for doing what I'm proposing. I do think it is feasible based on what we already know, but further convening a work group of people in the various agencies and mapping something out along the lines of what I'm going to suggest to you is what it would be. I'm asking that be done next year. An amount of money that would help to support a data scientist to collaborate with the members of the different agencies would be useful. But even if there were no money, I think that this is something that we ought to look into. So that's why I'm here. Now, the premise, as you well know, is that criminal justice reform and mental health services reform are inseparable. And that whole history of your project at SJ 47, demonstrates that just time and again, and we've already heard more about it today. So any systematic effort to measure the outcomes of interventions of either system, frankly, given the number of people with mental illness that are in the criminal justice system and the overlap with regard to people in the mental health services system, any systematic effort to measure the outcomes must include both subsequent criminal justice involvement as well as receipt of mental health services. Whether the mental health services part is an indicator of distress and crisis, such as through the TDO data and so on, or as measures of stability and well-being. And so that's the range of data that is needed. And ideally, if the system were more comprehensive, which I also think could be done, although that's not specifically, part of the immediate plan, is that you would include housing and employment data there as well. Now, this would all, let me just jump ahead to say that this is not based on individual studies. It's based on, and it's not essentially, when used, named or identifiable data. It's an effort to link the data systems on an ongoing basis in which then eventually the data would be identified before it is used. And it's all administrative data, rather than any kind of treatment records or criminal justice records. There are models for doing this. It can be done. It has been done. And my argument to you is we are in a good position based on some work that we've been doing with the department over the last couple of years, as well as some additional research grants, we think it is feasible to do this here, that Virginia, unlike many other states, actually has the capability to do this with regard to the data, and particularly the data with regard to emergency interventions through TDOs and civil commitment. Now, I want to give two examples of what we're talking about, and the first one I want to use based on what Heidi Dix presented earlier about mental special dockets. So the data that she presented earlier showed, of course, an effort to ascertain what some of the outcomes were of the people who had been enrolled in the mental health dockets, including subsequent involvement back in the crisis response system, as well as, I can't remember now everything that she said, but perhaps criminal records, of course, subsequent offending, as well. Now, my guess is, I haven't spoken with her about that particular set of data, but I'm guessing that there's a specific, inquiry that was made, that the request was, give us this information from the relevant records, and here's the list of people, that have been, in the mental health dockets. Give us this information so that we can find out what the outcomes have been, which is great, and we do have the capacity to do that. Basically, what I'm suggesting is that we ought to, and rather than relying, on individual inquiries where you basically have to commission the relevant experts and people who are managing the data to give you responses and be in the list of people who are making inquiries, that we want to do this on an ongoing basis. And again, as I said, that there are models basically to do that, so that on a periodic basis you stream the relevant data. And again, this is administrative data. Nobody's going into anybody's records. And initially, that it has names on it, has identities. But once it gets there, it gets de-identified before anything further is done with it. And this can all be done in complete compliance, of course, with all the ethical and legal requirements for such data. So the special docket, is a good example, because we want to know, when people who are in the special dockets, whether the people experience mental health crises or not, as well as whether they are rearrested. And there are just, I think, so many of the areas that relate to mental health services that you want to know prior criminal justice involvement, as well as subsequent criminal justice involvement. You want to know prior crisis involvement and hospitalization, as well as subsequent. Another example would be mandatory outpatient treatment. And this is another one. I know that the data, I give that as an example because in the connection with a study that we've been working on with the department, and that you'll hear some about, I hope, through SJ 47 this year, that we asked, again, specifically, for data with regard to a defined population over a period of time, and who had been involved in the commitment system, and then linked that data to information relating to certain, clinical outcomes and subsequent involvement in the system. We only for that purpose asked for data with regard to mental health and subsequent readmissions to hospitals, which was the key question of interest with regard to the mandatory outpatient treatment study is, do people subject to mandatory outpatient treatment have different trajectories, thereafter or not? We didn't, I think, if I recall correctly, we didn't ask for criminal justice data, in connection, with that, but that would be something else that you would want to know, is subsequent criminal justice involvement. All right, so, here are just two examples of which, there are many, given the intersections, between these systems. Competence to stand trial, and involvement, in for competence assessments and all the issues that then relate to possible determinations of incompetence, and then treatment, and then subsequent, if there are, what subsequently happens to the charges, what subsequently happens to them. There are lots of issues all over the country about what we should do about the flow of people into the jails, and many of whom are also arrested and subject to competence evaluations. So that's another. I mean, I was going to give two examples, but there's a third one, that is just all over the country. This is a huge problem where you can't even begin to think about intervening and doing something given possible policy alternatives with regard to the population of people who are being evaluated for competence and may have minor charges or not, unless you link the data systems to be able, to do this. So that's, as I said, what I want to persuade you is this is something, that is really needed. So given those examples, the data systems need to be linked on an ongoing basis rather than doing this retail. It is a challenging and technically complicated task. I don't want to, the reason it hasn't been done, by now. Fortunately, in many places, I don't think it could be done because they don't have the administrative data systems that would allow you to do it. Virginia does, because we have the commitment system that we have, which is judicially grounded. And we therefore have data that the Supreme Court has collected and that we've then connected up with the mental health data. That's a huge problem in states that basically don't have a judicially administered, commitment system, and it's highly localized and so on. And in fact, it's been written in the literature. Frankly, everybody ought to do what Virginia, is doing, because we have the data to be able to actually, ascertain about what some of the outcomes are with regard to the way the system operates, as well as the outcomes. But many states couldn't do it anyway because their system isn't really designed. There would have to be other things that would be able to be done. All right. So the next final point I want to make to you is we can do it here. Not only because we have our certain data that other states do not have, but in addition, we have had experience recently. I wouldn't have come here 2 years ago and said this can be done here. I don't, because first of all, I'm not a data scientist, so I couldn't have said it anyway. But I've learned something, over the last couple of years, because we have had grant-funded research that has, again, it's specific requests, right, that we had to ask the agencies, for the data, but the kind of data that we're talking about here, in order to be able to, just to give one example, under the Brady law, people who have had histories of civil commitment are disqualified by virtue of having had the civil commitment from purchasing a firearm. So it's one of the disqualifiers. And there have been questions. There's never been any study about what are the effects of this. Obviously, you would hope, the premise, of course, is that people are at elevated risk, but they're committed. They then are disqualified from being able to purchase a gun. The way it is now, it's a lifelong disqualification, but you can petition for having your rights restored. Well, presumably there's a risk assessment, that has to be done. So clearly, the stability of the person with regard to any subsequent mental health issues, as well as their criminal justice history, is clearly relevant to determine whether or not that this is a successful. What are the effects? I don't want to say whether it's successful or not. What are the effects of the disqualification? We had funding from the National Science Foundation to do this. There were several other states that were also subject to the study. So in doing the study, we had to do the kind of linking of the data that I've just described to you. And we were able to do it. We are still I wish I could give you the result of the study. I can't, because we're still doing the analyses. But what we do know already is that the data were successfully linked so that we actually can be confident that it is valid. We're validly measuring the system involvement of the particular individuals, because we were able to relink the data and so on. It's de-identified at that later point. But nonetheless, people in our collaborators on this are at Duke. Jeff Swanson, who is a professor at Duke, was here earlier. I asked him to be available to us. Unfortunately, he had to leave an hour after you began. But we were working with him. They have the data. They are analyzing it. Based on that, it shows that this is something that can be done in terms of actually linking the data that we've just described and setting up a protocol where it could be continuously streamed to a hub, right? And the hub, the way that I'm proposing this, would be DBHDS working with us at the hub in order to be able to, clean up the data and then to be able to use it in response to requests that you would ask with regard to what the policy effects are. So that's basically the plan. There was something else I wanted to say about. Oh yes, we've had a second study. We had a second grant that we've actually done this again and are working on it again with additional criminal justice data that we had not been using the last time. And again, it seems to be, panning out. So in principle, it does look like this is something that could be done. We're at the threshold where it makes sense to put this, in place. There doesn't seem to be any reason technically to wait any longer to begin to, to ascertain whether I'm right about the feasibility and cost, of doing this. All right, so that's basically, what I want to convey to you. There's more of the detail with regard to the Section 1 bill that I've just outlined. I can give you some specifications about what the objectives would be of this feasibility study, but basically we're asking for a feasibility study. So a year from now, we could say, this can be done, do it.
Thank you very much, Professor Bonney. And again, I would draw to the subcommittee's attention that Professor Bonney is Director of Institute of Law, Psychiatry, and Public Policy at the University of Virginia School of Law. And the reason why I highlight that title, that really brings it all together as far as the proposal being made, and almost uniquely so. But before I turn to Delegate Bell, who I know has also looked at this proposal, as I understand what is before us as a subcommittee, is that whether or not we bring this before the full committee later in December as to whether or not this is something that the Deeds Commission might actually endorse as legislation for 2021. Obviously, whenever you endorse something, it is in concept. It is not in every specific detail. That's what the legislative process is all about. So that is, again, what is before us as to whether or not we would bring before the full committee a proposal for a Section 1 bill that would direct cooperation between the Office of the Supreme Court, the Secretary of the Supreme Court, state police, DMAS, mental health, and to have these various data points fed into a database, relational database, where they can be teased out and used in different ways to try to measure outcomes of a number of programs. Delegate Bell, did you want to follow up? Or any comments about whether you think this is a something that needs to, can we take advantage of these initial grants?
No, I love data. I mean, I think it helps all of us do a better job. These are, I guess, questions for you, Madam Chair. Any bill that we do out of the committee would still need to, or commission would still need someone to carry it. Is that right?
Yes, right. Mm-hmm. And I am full. I know you had expressed some interest since Professor Bonney sent this to you and to me initially.
I have not I wanted to file all at once just so I could see what had come in. I'm saying I don't have it. I'm not full, but I also am not sure I have a slot. I was just, I mean, again, this is not final language, but I like data. And so I would certainly hope that we would endorse this, and then we may not prioritize it. That's a harder decision, but I mean, I like the idea.
Understand. Yeah, and Matt, I got it to you late. Let me, admit that too. I just was caught unawares about what was going on with the bill limitations and so on. And while we're just getting the record clear on this, I've given you the Section 1 bill. There is also another simple amendment to an existing code section regarding the reporting of reporting or the notifying having the Supreme Court when they have an order for a competence assessment to send that order, which they already have to send out to the parties and to the when the district judge sends it out, that they should send a copy to the department also. Right, they are already doing it, and send a copy to the department, because right now there is no administrative data set that would give us that information about evaluation. So that is in the package also.
Are there other questions, concerns?
Yes,
Jayla,
Madam Chair. Yeah, I'm sorry.
No.
I've been using the raise your hand. I'm trying to get everybody's preferences and things.
Well, but, right now I can see you all, so it's okay.
Perfect. So I had a couple of questions, just knowing what I used to do as chair for the Behavioral Health Committee. It was just like a lot of the recommendations that had come with the stamp of the Deeds Committee. It seems like there had been a lot of input. And I do feel a little rushed in this. And so I wanted to just see if we could slow down and take a little bit more time, at the risk of it being today. But, just having some questions. I believe 2 of the entities that were listed in this partnership are here. I would love to hear feedback from the department, from OES, and then if they're able. And then also, when I was working on a potential Section 1 bill for special session, I had named a university entity to work with the department, separate topic. And I was told that the proper wording for a Section 1 bill is to tell them what you would like for them to get to, but it was not appropriate to name necessarily all of the people that they had to work with in order to get to that. And so I just wanted to flag that, because I was given that information with something else. The way that it is currently presented is directing the department to work with the specific entity, as opposed to the outcome that it is that we're looking for. So I had, and maybe that's a question for staff, but just the institutional knowledge, I don't have on that, but I would love to hear from the department and OES if that is appropriate, Madam Chair.
Oh, it is very appropriate, and it is my oversight that I didn't turn first to Christy Wright. Christy, could you share a comment, please?
Sure. Thank you, Madam Chair. Christy Wright, Office of the Executive Secretary, Supreme Court. So we have not seen the Section 1 bill. We were not aware that that was coming. So I have a difficult time. I won't be able really to speak to what it's asking in great detail. In listening to the comments, I do have a few responses. One, there was a reference to the data that we are collecting. We don't collect data. What we have is case information. And so that is actually what the clerks maintain to assist them in processing the case. I know it's of interest to many people. Many people want it, but it is designed to serve the purposes of the clerk and the court. With that, I would also add that that is not, in fact, the criminal history. And so only the Virginia State Police really has someone's criminal history. We do not have Fairfax and Alexandria circuit courts do not participate in the statewide case management systems. We do not have access to that. That would have to be handled separately. And then also related to that case information, I would add that in light of the discussion about expungements, that we have been involved with. I know are out there. I know it will be returning probably this upcoming session. I would also just kind of, put on a warning out there that I know he's saying it would be de-identified, but one problem may be that it may not exist at all. If what's being contemplated is, and I bristle a bit at the term automatic expungement, it's really a petitionless expungement. There's nothing automatic about it for the clerks and the work that the clerks have to do. But there have been proposals to have an expungement immediately upon, say, a dismissal or a null pros at that time, and then that information would be eliminated from case management. So, there is an interplay of wanting to give people fresh starts, but then also maintaining that information, and I think there's a rub there. Just wanted to bring that to your attention. The other thing that was noted, yes.
Delegate Watts, could I just make a couple of comments?
No, I'd like to have Christy finish, and then
I'm sorry, I didn't know that she wasn't.
Yeah, the one other thing I want to comment on that proposal, again, I haven't seen it, but the talk about linking, I would caution with that. I'm not an IT person, but I've been around our systems enough to know that that will likely cause some significant technology and security concerns on our part. If what you're really talking about is linking, or if what you're talking about is extracting case information from our systems and then providing it, that's very different than a linking or a streaming that was mentioned. And again, not an IT person, but I do think there would be some security and technology questions. The other proposal that he is, Professor Bonney has spoken of, I am aware of that. And I have raised concerns with him and about that, really about the placement of that responsibility on the clerk, and that it is misplaced. It places yet another duty on the clerk, and most importantly, it places a duty that's not court related. It's not at all related to the work of the court and what they would need to do. And I know it sounds like a minor thing, but the clerks, if you take a look at the manuals that are online for what the district court clerks are supposed to do, there are hundreds and hundreds of pages of acts that they are supposed to do for each case, and then each scenario within those case types. And the expectation is that they do it all correctly, and an expectation that they do it for really are pretty low wages. And so we ask much of them. And it's one thing to continue to place burdens on the clerks when it's for a court-related purpose, but to do so for something that would be for ILPP's data collection or DBHDS or whomever, I find that difficult to justify. So the evaluators are sent the order, and those evaluators, because that's the court purposes, the order is going to the evaluator, ordering them to evaluate this person for competency to stand trial. They are DBHDS certified, and it would seem more appropriate for that mental health related information that be something that the evaluator would either feed into, whether it's, and I don't know how this all works, whether it's a CSB or an independent evaluator, that they would then feed that information on to DBHDS rather than having the clerk for a non-court related purpose be the provider of that information. Thank you.
And Professor Bonney, if you'd like to respond, and again, I do apologize, but I am aware of the time and we have a couple other things on the agenda. So if you could be tight on the response.
Yes, I will. I think I can deal with all the qualms that Ms. Wright just raised. We're not asking them for data with regard to criminal history. That's coming from the state police. As I said, we've been through this through research grants that have been funded, and we've gone through all of these procedures. There's certainly, from the protection of the privacy of the individuals, everything that's done routinely in connection with these studies. This is policy research for mental health and criminal justice policy. So it is certainly in the interest of the Commonwealth. It's not to give us the data. With regard to the Supreme Court's other data with regard to civil commitment, there would be nothing more that the court needs to do other than it's already doing, which is that it sends the data to the department. It's already there in the hub, which would be the department. So we're not asking for anything further from the Supreme Court on that. That's the data that's needed. And so I called it streaming, but essentially it's data that's just routinely given because we're using it for policy purposes, ever since the Supreme Court Commission, and to very good use. So the final thing I think is this issue with regard to the new data that we're asking the court to produce. And all I can, would say is this is for a public purpose. It's an important public purpose. They are the only ones that have the data. If we could get it from someplace else, we wouldn't bother the Supreme Court. But they have the orders for competence assessments. And all we want is a copy of the order. The statute requires the clerk to send the copy of the order to the parties. And, it seems to me that it's a minor, addition to say when you're sending it to the parties to send it to the parties.
And before we, Heidi Dix, do you have anything that you'd like to add from the DBHDS side?
Yes, thank you, Madam Chair. So I have also not seen the Section 1 bill, so I can't really weigh in on that. I will say, with just particular to the order, if an order was to come to the department, that would require us to have someone to receive the order and then require us to somehow make sure it gets appropriately into our data warehouse and then have another person to help pull the data. So this is not something, and I have shared this with Professor Bonney, this is not something that would be for free. We have a lot of obligations on the department, including in the data management area. And so we would need to make sure that we had the ability to do it. So that was my primary concern that I expressed to him. And on the feasibility study, we would be happy to take a look at that. I mean, we do know this is an area that needs research, but we would, again, we have a lot on our plate, so we need to make sure we're able to do what we're being asked as an organization.
Thank you very much for that input. So now it's on our agenda as to whether or not we feel that it's something we want to move on to the full committee from endorsement. That doesn't mean that we're saying no, that it shouldn't be endorsed, but it's just whether or not we think it's ready for the commission as a whole to endorse, as Delegate Price was referencing things that come from the commission. And again, this is one of those unusual years where we're more telescoped than we would like to be, in the wrong way, not in the sharp focus way when I use the analogy to telescope. Is there any comments about whether we should move this forward?
Yes, Madam Chair, Delegate Price. So I have concerns because the first thing that I thought about also was the expungement. I'm on the vice chair of the Barrier Crimes Commission, and we are trying to link up our own stuff with the expungement. We also know that the House and the Senate had different, it's just so many unknowns in the space of the expungement. I think, having heard from all three parties, more questions got created for me than necessarily answers. And I do want to respect the time, but I also want there to be full conversation about this before I say, yes, I endorse something, because I know what that means moving forward. It gets the ball moving pretty clearly for the path to passage. So is there anyone on that has the institutional knowledge as to the wording of how Section 1 bills typically go for that question? And then 2, is there other space, or is this the only time that we have to make this decision about endorsement, minus some of the security questions that were being brought up, or the expungement, how it would align with expungement, those sorts of questions? Sarah, do you want to handle both questions?
Of course, I can do so. With regard to the wording of Section 1 bills, I will say that traditionally what we do is, in a Section 1 bill, direct a state agency or entity to carry out a task. We can provide some information around who you might want to include in that process, but we do leave leeway generally for the state agency to figure out who are the most appropriate stakeholders and how that process would work. So that part would need to look at how this is organized and worked out. The other part of that is, of your question, Delegate Price, is that we have the full joint subcommittee meeting on the 21st of December. We weren't planning another work group meeting before that. I'm not sure we'd have time, to be honest. Yeah, there's already been some talk of at least an additional work group meeting for one of the other work groups sometime after the meeting on the 21st and before the beginning of the General Assembly session, which is coming up very quickly as well. But I don't know. That will be up to the members to decide how you all would want to handle additional opportunities to have a work group meeting if that's what you're looking for.
Thank you. Delegate Ransom, Delegate Bell, do you have any comments? I know that Rob is trying, so I'm waiting for the unmute. There we go.
I mean, I don't have strong feelings. If we don't do it today, I think we will find that we run out of time. Now, that doesn't mean we sometimes advance things in concept, but I don't want to, I didn't come into this having studied this at length, so I don't want to trample on Delegate Price's concerns either. So,
Delegate Ransom, you're on.
And I haven't gone through the legislation specifically, but I mean, we could look through it over the course of time, and we can email back and forth with each other. And then once we get to full committee, decide beforehand. I mean, we could talk about it and decide whether we want to move it forward.
And then hopefully somewhat reflecting what I think is a consensus, I will start by saying I would not have asked this to be on the agenda if I wasn't like Rob Bell. Data is good, and that bringing these things together is important to really know whether or not we have the right emphasis, and having all of these various components to be able to recombine into various questions, I think is very healthy. But I am concerned that because of the fact that this is the only meeting that we've had, and it's also reconstituted, I'm not sure that we're ready for prime time. Now that, again, I will emphasize, that doesn't mean that I don't think that Professor Bonney, and with whatever sponsor you can work with, that not to go forward with it, or to go forward with it without the Section 1 direction. Obviously, you've already talked with the Office of the Executive Secretary and with DBHDS, and continue that efforts. And again, if something emerges between now and the 21st, or certainly between now and, let's say, the 19th, give us 2 days lead time at least, then it's possible that it might be on the full agenda. But I'm not sure that we're ready because of the press of time this year, without the special session and COVID, to have been able to give this the full attention for our endorsement as opposed to our individual encouragement.
Madam Chair.
Delegate Price and Professor Bonney, last word.
Yeah, I did have one additional concern as well with the timeline. I know that the governor's introduced caboose budget will be, I think, the 16th, and then the money committees will start, answering the questions and things like that. So if it is going to be, I mean, who we have on the Deeds Commission does have a lot of say within those, those spaces. So I would also anticipate we would need to know a general amount that we'd be talking about as well. So I don't want the financial pieces that were raised to be left behind in those conversations that we're going to have.
Well, I was looking at the text that we were provided, and the statement is this is being sought even if there is no appropriation. It's more the direction that this is an important enough effort for us to direct that this kind of cooperation and working out the details was something that this group would feel was important. So the appropriation wasn't conditional. To answer your question, as far as the money committees and the governor's proposed amendments, this proposal, as it's stated in the proposal, is not conditioned upon an appropriation. It's being sought even without an appropriation.
And if I could just one final thing to say on, if Delegate Price and I could have a conversation, I think I can convince her that the expungement is not an issue here. This is completely de-identified data. It will have no impact on any individual at all once it's sent and aggregated like this. Every criminological research and criminal justice research that deals with arrests and convictions, you know, you have the question about what if it's been expunged. In the aggregate, the number of expungements probably doesn't affect the overall findings, but it's not identified, right, at all. So if there were possible to integrate expungement into the database, that would be the ideal. But I think in many of these studies, you know, there's always the possibility that some individual records have been expunged. But once the data are de-identified, you can't identify any particular individual. So it's not that they're being disadvantaged when, if you only knew that conviction in 1994 was expunged. So I think we can have that conversation. I think I can satisfy you. That's not a problem for what we're trying to do here. It's a big public policy problem what to do with expungement, but it doesn't affect, I think, what we're trying to accomplish with this data. But I'm happy, would love to talk to you about it.
On the ongoing effort. Thank you so much. If there are no other comments, the next item on our agenda, is there other proposals for the 2021 session that we should be considering to bring forth to the full commission?
Madam Chair.
Yes, Delegate Bell.
So as you said, the compressed calendar is really kind of making it difficult to have an idea that's just an idea and then have staff work on it and then have people kick it around and then maybe we like it. I'd like to raise an issue for this group. I'm not sure I see a way to move it forward, but I'd like to at least raise it in case everybody is hot to trot and maybe we can work on it. The issue is that we have a large number of Virginians taking care of special needs family members who never go through the full formal guardianship proceeding. And everybody that's talked about it with us in various groups and committees and whatnot have said that almost nobody does. That almost everyone that takes care of either a senior or a 18-year-old who's turned 19 but special needs. And the reason is it's very hard. And I don't mind sharing that we're going through this right now with my son who's 17, about to turn 18. And even for a lawyer who's working with a lawyer he's known for a long time, it is a arduous undertaking that requires bookkeeping. And there's a lot of reasons why people don't do it, even though probably it would be something we would like to have. Last year, there was a suggestion or a proposal, I don't recall if it was a bill, that other states have a much simpler and admittedly less involved process for assisted decision-making. And you don't get all the rights and privileges of guardianship. You don't take away the various rights that they lose when you become the guardian. But for most people, it would be an attractive way to give them some legal authority, some legal protections, without making them go through what is, I mean, I would say thousands, but certainly $1,000 and court hearings and all the rest. That feels like this is something we could productively look at. It's hard to see how it's constructively possible at 3:34 on our one meeting before we get to the full commission. I don't have a bill. Somebody sent me a bill. I've got it drafted, but it's not ready for prime time. But it's also, and I guess Sarah's waving it, and she may have some good ideas. But Madam Chair, that would be a suggestion, understanding that the answer may be a good idea for a later date, but not today.
Sarah?
Delegate Bell, just to give you a little bit of background information generally on where that topic stands, you'll recall last year we had the supported decision-making bill in Delegate Price's subcommittee, in fact.
I did not remember that, but that now you're reminding me. Thank you.
That's where we had, yes. So it was, I can't remember if it was carried over or if it was tabled, but DBHDS did a study of the topic at the committee's request and has completed their study, and the report came out a couple days or weeks ago, kind of lost track of time. But I was reviewing it this morning, and in fact, it lays out a pretty clear statement of the work group had some solid consensus around the topic and some ideas of what might be appropriate for the Commonwealth moving forward, talking about ways to make clear that supported decision-making is an option available to the people in the Commonwealth already under the current statutes, but more importantly, ways to increase education around and awareness of supported decision-making, some training for individuals who might choose to enter into a supportive decision-making, their family members, supporters, and then also professions that might interact with individuals who have a supportive decision-making in place, some model agreements and those types of things. So I'll forward you that report. I can forward it to the whole subcommittee. It's a really well-organized, well-done work group and report that lays out the concepts very clearly. So I'm happy to share that with you.
Madam Chair, might I ask Sarah a question?
Yes, please.
Ms. Stanton, I didn't hear a need. I'm not looking to do legislation if we don't need it. Was there some gaps that needed to be filled in? Or, because like with advanced medical directives, which has some similarities in my head, that was always possible, but so complicated and expensive that no one was doing it. And so we then passed some bills, and my recollection is actually put some model language in the code, or at least made it very obvious and easy. And I'm not saying that solved the whole problem, but it did make it more everyday citizens who think this is a good idea could more easily access that legal construct, I guess.
Delegate Watts.
Yes.
My understanding of the situation is this: supported decision-making, like the advanced directive of 10 years ago or whenever we worked on that, it is already available. You can already enter into one of those agreements. The issue is exactly what you've identified, that people may not be aware of the option. They may not be aware of how to enter into that option. Others with whom they interact, service providers, family members, whomever, may not have the understanding necessary to work in that context either. So the legislation, while not strictly necessary to make supported decision-making available in the Commonwealth, could have the impact of making it more user-friendly and more widely utilized in the Commonwealth by providing that education, training, support, some models and those types of things.
Madam Chair,
Yes,
if I might, just for everybody's, I don't know, even edification probably is too strong, but I think what I would ask is that we not do anything on this. I'll talk to Ms. Stanton if there's something that looks ready enough to be productive. Most of us are on the right committees anyway. You'll see it a little later. And then if there's something big, we'll just wait till next year. I think that would be an appropriate way. Thank you.
Anything else that someone would like to bring forward? If not, Sarah, is there anyone waiting with public comments?
Yes, and MJ, I believe, has the list. He's here and can tell us who those individuals are.
Thank you.
Madam Chair, we do have Nora King with us now.
Nora King, I can see your name. If you can unmute yourself, if it's possible to go on video, it would be good to be able to.
I see that there's no one represented on your panel today, but are you working directly with anyone from the criminal justice system to, towards your goals?
We are having a hard time hearing you. If you can get closer to your microphone, that would help.
Are you working directly with anybody in the criminal justice system toward all of these goals that you're trying to accomplish? Because there's no one on your panel today from the criminal justice system.
The question was, are we working with the criminal justice system? Certainly, as this particular subcommittee has morphed from one that was purely the interface between the justice system and mental health. We have that as part of our purview, but it's also expanded beyond that. And perhaps the reason why our agenda today was more oriented towards other special populations, I can assure you it does not at all change the focus on as was mentioned in the first presenter, about diversion and the whole spectrum of at every point trying to divert, but making sure that there are mental health services that you are in fact diverting into. So please be assured that what you heard in the first presentation is something that represents continued work directly with the justice system.
Okay, thank you.
Mm-hmm. MJ, is there other?
Madam Chair, that is all that we have for public comment.
Thank you. So again, I think we've touched on this. We'll see each other, such as it is, on the 21st, in part because of this unusual year. We will not, as I understand, be bringing forward anything. I thank you very much, Sarah, and all of the presenters, because I feel much more informed about whatever may come before the commission, to the degree we're able to act on anything coming up for the 2021 session. But certainly I look forward to far more robust meeting schedule in the next 12 months, because there's so much that so many of us from each of our perspectives have identified and are concerned about. And it is, I remain very optimistic that these things are in fact being dealt with, highlighted, rather than being behind closed doors. And it's a matter of our commitment and resources to bring it together for all the individuals and families involved. Any other comments? If not, I will see you all on the 21st. Thank you so much for your efforts.